Assalamu alaikum, guys. My name is Rida Shahab. I'm a second-year medical student, and today I'm going to be covering the topics vitamins 1 and 2 of biochemistry. This is a long lecture, but I have gotten everything covered in the slides, so the past session shouldn't be that long. So let's get started. Here are my contact details. If you guys have any questions by the end of the lecture, you guys can reach out to me. I'm here to clear all the doubts. Okay, so Bismillahirrahmanirrahim. Let's start. So what are our topics for today? We're going to be discussing what are fat and water-soluble vitamins, what's the function of vitamins, vitamin toxicity, as well as vitamin deficiencies. Okay. So what exactly is vitamins? So vitamins are organic compounds which are necessary in smaller amounts for our body. That is also why they're called micronutrients, because you take them in smaller amounts. Okay, and although these substances are taken in smaller amounts in our bodies, they're very essential for cellular metabolism processes. Okay, and their absence is usually manifested as some deficiency diseases. So before vitamin terms was given, where did it come from? This is just a fun fact that Dr. Hannah added in her slides, so I'm just going to talk about it. Vital amine was a term that was given to thiamine, which is one of our vitamins that we're going to be discussing, because thiamine was used to prevent beriberi, which is the deficiency that's caused by thiamine. So you take thiamine to prevent beriberi. That's why thiamine was called a vital amine, which is where the term vitamins come from. Okay, so this is just a basic talk about what vitamins are. Okay, now what's the lovely coenzymes for nerds? So this is a mnemonic that Dr. Hannah has passed down to several batches, and learn this like your last name because this is really important and it's going to be really beneficial for you. Okay, so the lovely coenzymes for nerds are basically, it's a mnemonic for coenzymes that are required for these enzymes to work. These enzymes, these three enzymes that you see here, these require these five coenzymes to be working in their processes. Okay, so the five coenzymes are thiamine pyrophosphate, which is B1, which is where we're going to discuss, lipoic acid, which is not a vitamin, so we're not going to be covering this. We have CoA, which is B5, FAD, which is B2, and NAD, which is B3. So all five of this are very essential for these enzymes to work. So let's say hypothetically, if one of these five is not working, these three enzymes are not going to work because enzyme needs a coenzyme to work, okay? So pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branched chain keto acid dehydrogenase need these five coenzymes. So let's say we have a beriberi deficiency, which is thiamine pyrophosphate deficiency, okay? And we don't have B1 where our diet doesn't consist of B1. So what's going to happen is pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, and branched chain keto acid dehydrogenase are not going to work because one of these five enzymes is missing, okay? So what happens is pyruvate dehydrogenase is not going to convert your pyruvate into your acetyl-CoA. So it's just going to be stuck in that path, and instead it's going to get converted into lactic acid and potentially cause lactic acidosis, which is bad for your body. That is why these five or four that we're going to be discussing are really essential for our body. Okay. Moving on. Vitamins are broadly classified into two categories. We're going to be talking about water-soluble vitamins as well as fat-soluble vitamins. So first, we're going to be covering water-soluble vitamins, which are complexes of B and vitamin C. Okay. There's also folate and cobalamin, which we're going to be covering. So let's start. Okay, so water-soluble vitamins are basically vitamin B complexes as well as vitamin C. And one thing is they're not stored in the body. So with your common sense, you can already tell if they're not stored in the body, you need to take them from your diet. So your diet must be enriched in these vitamins, okay? And when you consume these vitamins in excess, they're going to be eliminated in the urine, okay? And deficiency of these vitamins is going to be more of a concern than toxicity because it will indicate that you're not taking these vitamins in your diet. So it's going to be more of a concern than toxicity because you're not consuming these in your diet and you need to. Okay. Exceptions of vitamins that are stored in the body are B12 and folate. You still take them in your diet. It's not like you're going to eliminate from your diet, but they're stored in the liver, okay, as well. And they play a role as coenzymes, which we just talked about. And this is a diagram here that you can see. This is an enzyme and this is a coenzyme. So coenzyme is basically it's like a non-protein molecule that attaches to your enzyme to make it work more like better, to enhance the working of the enzyme, okay? And our coenzymes in this case are going to be the lovely coenzymes for nerds, okay? So let's start. So these are our water-soluble vitamins. I know this looks a lot, but inshallah, by the end of this lecture, you're going to have all of these enzymes in your mind, and it's going to be really easy to interpret. So we're going to start with B1 thiamine. So in this table, the names that you see here are the names of the vitamins. So B1 is called thiamine, B2 is called riboflavin, and these here are the coenzymes that these vitamins give rise to, okay? Okay. So B1 thiamine is a precursor for thiamine pyrophosphate, which is a coenzyme, which is the lovely coenzymes for nerds. So the T stands for thiamine pyrophosphate, which is obtained from B1 thiamine. And thiamine pyrophosphate is an important cofactor for several enzymes like pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branched-chain keto acid dehydrogenase. And all three of these, we just discussed them in the lovely coenzymes for nerds, but there's a new one that's being added here, which is transketolase, which comes in your HMP shunt. So your HMP shunt is basically the electron transport chain you guys must have taken. So that's where transketolase comes, okay? You know all three of these, you just need to add transketolase. So I do have a mnemonic for you guys to remember this better. So thiamine so thiamine is something that you need for ATP production, right? Every vitamin is essential in your body for energy metabolic processes, okay? So the mnemonic here is ATP for B1, which stands for A stands for your alpha ketoglutarate dehydrogenase, T stands for your transketolase, which is in the HMP shunt, P stands for pyruvate dehydrogenase. For B1, so B1 can also stand for thiamine as well as branched-chain keto acid dehydrogenase, okay? So all four of these enzymes need the coenzyme thiamine pyrophosphate to be working, okay? Is that clear? Just write yes or no in the chat. Okay. So also something you need to keep in mind is if there's a deficiency of B1, you're not going to have ATP. So the energy metabolic processes are going to stop. Okay, let's start with the deficiencies. So what causes B1 thiamine deficiency? What are the causes of it? Okay, so the two most common causes of thiamine deficiencies are alcoholism as well as malnutrition. And alcoholism is also given the term of Wernicke-Korsakoff, which is very important because if you get a clinical scenario with a person that has been diagnosed with Wernicke-Korsakoff, you need to know that that means that, it's a term for alcoholism. And the patient usually presents with memory loss, unstable walk. So memory loss is basically they're going to present to your clinic in confusion. They don't know where they are. Unstable walk just tells you what it is. And what exactly happens is alcohol is ethanol. So when you take ethanol, this is going to affect your thiamine absorption. And you're not going to be absorbing thiamine well, even if you're taking it in your diet, which is what causes thiamine deficiency. Okay, the second most common cause is malnutrition, which causes beriberi, which is what we just covered in one of the first slides, which is a neurological disorder. Malnutrition means that you're not taking thiamine in your diet. So you're taking white rice or non-enriched rice that lacks B1. And if you lack B1, your enzymes are not going to work because B1 is not giving you the coenzyme thiamine pyrophosphate for your four enzymes to work. ATP for B1, they're not going to be working because you don't have the coenzyme from thiamine, right? So PTH, which is pyruvate dehydrogenase activity, is going to decrease because thiamine pyrophosphate is not there. It's not in your diet, which is why you're going to have less glucose breakdown and there's going to be ATP depletion. So there's going to be no energy metabolic processes that are happening. Okay. This is one of the expected scenarios that is going to come in your exam or maybe an MCQ question. And it's going to be it's going to be talking about a 52-year-old chronic alcoholic presents with confusion, ataxia, and slurred speech. So here he presents with confusion as well as slurred speech, okay? He appears malnourished with a history of poor dietary intake and vomiting, which already gives you the two most common causes of thiamine deficiency. He already has them. He's alcoholic as well as he's malnourished, right? So he doesn't have thiamine in his body. So how do you treat this guy? You're obviously going to give him thiamine first, right? You do not give him glucose because the glucose processes are already stopped because the thiamine is not giving you thiamine pyrophosphate, okay? So you're not going to give them glucose because first you need to administer thiamine for thiamine pyrophosphate to work, and then all the metabolic processes are going to work, and then you give them glucose, okay? So thiamine is going to come first, after which you're going to give them IV glucose, okay? Do not give IV glucose first. It's very important. Okay. We're going to go to our next vitamin, which is B2, riboflavin. FAD and FMN are the precursors, are the coenzymes that are going to be derived from riboflavin. So riboflavin, the precursor for FAD and FMN, we just talked about it. Riboflavin is B2 and it gives you FAD and FMN, which are coenzymes. So the lovely coenzymes for nerds, we talked about thiamine pyrophosphate, which comes from B1, not C, sorry, F, which is going to be from B2, which is riboflavin. Okay, riboflavin is a cofactor for dehydrogenase, which is succinate dehydrogenase, which comes in your citric acid cycle. So if you know your citric acid cycle, you know that there is an enzyme called succinate dehydrogenase. Okay, and riboflavin deficiency is also caused by severe malnutrition because you're not taking it in your diet. And one of the major symptoms that you're going to see in these patients are going to be one of these three. So there's going to be ileosis, which is inflammation around the lips. So you can see there's going to be inflammation around the lips, scaling and fissures around the corners of the mouth. There's going to be glossitis, which is magenta colored tongue, or corneal vascularization. Okay, so the patient is going to present with either all three of these or one of these, okay? Okay, we have B3, which is niacin, NAD+, is our coenzyme, and it's required in high amounts, and it can be synthesized in the liver. So our precursor for niacin is going to be tryptophan, okay? And it gives rise to NADH and NADPH, which are our main coenzymes. And we know NADH is for ADP production in the mitochondria, and NADPH is an important reducing agent in biosynthetic reactions, okay? This is very important too. Niacin deficiency causes pellagra. Very, very important. It's a very high yield concept. They usually ask about it. And pellagra is classified by triple D. And the triple D here is dermatitis, diarrhea, and dementia. So dermatitis is basically lesions on the skin. Diarrhea, everyone knows what diarrhea is. And dementia is forgetful memory, okay? Or short, like kind of like, forgetful memory, okay? So this is what is caused by the deficiency of niacin. What is the toxicity of niacin? So you give niacin in higher doses to patients that are suffering from hyperlipidemia. So hyperlipidemia is when the patient has high amounts of fatty acids in their blood. So you give them niacin to bring this fatty acid level down to normal, okay? And as a side effect to giving these patients niacin, you can see facial flushing on their face, okay? So this is the toxicity. Okay, so overall, we talked about B1, B2, B3. Let's just go over them all together. We talked about B1. We said the two causes are alcoholism as well as malnutrition, okay? For B2, we said there's going to be three symptoms the patient is going to present with, ileosis, glossitis, as well as corneal vascularization. And B3, we just said the deficiency causes pellagra, which are the three Ds, whereas the toxicity causes facial flushing when you give the patient niacin in hyperlipidemia. Okay, now B5 is pantothenic acid, okay, which is an important precursor for coenzyme A, and deficiency of B5 is really rare. All you need to remember for this is PAF for B5. So we have three mnemonics in this lecture, in this PAL lecture, okay? The first one was the lovely coenzymes for nerds, which you guys already know. The second one was for thiamine, which was ATP for B1. And the third one is PAF for B5. Now, what is PAF for B5? So P stands for pantothenic acid, which is what is the name given to B5. A is for acetyl-CoA synthesis, which is one of the main processes of B5, and F is for fat metabolism, which is also one of the processes for B5. So this mnemonic just wraps up B5 in a short sentence, and the deficiency is rare. Okay. Moving on, we have B6, which is a pyridoxine or pyridoxal phosphate. So there are three forms of pyridoxal phosphate, okay? So there's a pyridoxamine, there's pyridoxal, and pyridoxine. So pyridoxine is the one that's present in plants, and pyridoxal and pyridoxamine are present in animals. All three of these, however, are converted into pyridoxal phosphate, which is one of our main coenzymes. okay? And pyridoxal phosphate is a very important cofactor for two important processes. So we have metabolism of amino acids as well as synthesis of heme. And you can just tell by knowing that it's important for synthesis of heme, right? So if there is a deficiency in B6, it's probably going to cause an anemia. And the anemia it causes is called sideroblastic anemia, okay? Now, how does it cause sideroblastic anemia? We know that it helps in the synthesis of heme. So it breaks the building block for heme, which is ALA, aminoclavulanic acid. And if you have B6 deficient in your diet or in your body, you're not going to be making this building block of heme. So you're not going to be making heme. So there's going to be no heme for the iron in your body to bind to. So your iron is actually going to accumulate in your RBCs, and your RBCs are eventually going to rupture and cause anemia. Okay, so this is what causes sideroblastic anemia. And in this picture here, you can see that RBCs have iron accumulating inside them because there's no heme for the iron to go to, okay? Okay. Another very important topic of pyridoxal phosphate is isoniazid. Isoniazid is one of the drugs that is used to treat tuberculosis, okay? And this drug, isoniazid, has a structural similarity to pyridoxal phosphate. So it's structurally similar to pyridoxal phosphate. And when you give this drug to the patients, right, the patients, like the body thinks that they mistake it for B6 and they actually inactivate pyridoxal phosphate, which is bad and can lead to B6 deficiency, okay? So how are you going to prevent this? Is you give them B6 supplements along with their tuberculosis medicines, okay? So you give them isoniazid. Patients are also going to have B6 supplements so that they can avoid B6 deficiencies like sideroblastic anemia, okay? Now we're going to be talking about B12, which is cobalamin, one of our very important enzymes. Sorry, vitamins. Doctors love this one. Okay, cobalamin is used in the synthesis of thymidine. Sorry, used in the synthesis of thymidine. And thymidine is one of the bases in DNA, so you already know that it's important. Okay, it's also used in the metabolism of homocysteine, which is methionine metabolism. And cobalamin deficiency is going to cause decrease in DNA synthesis, which is going to cause megaloblastic anemia. Okay, what are the causes of deficiency of cobalamin? So one of the main causes is gastric bypass surgery, which is when you basically take a part of your stomach out to reduce fat. Okay, that's what gastric bypass surgery is. And your stomach has intrinsic factor that helps B12 get absorbed easily. And if you're taking out a part of your stomach, there's going to be less intrinsic factor. So B12 is not going to be getting absorbed in your body, which is what causes a deficiency of B12, which would lead to megaloblastic anemia. Now, how do you differentiate megaloblastic anemia with sideroblastic anemia? Is megaloblastic anemia's picture is going to have hypersegmented neutrophils, whereas sideroblastic anemia, if you recall, it's going to have RBCs with accumulation of iron inside it because there's no heme, okay? That's how you differentiate between sideroblastic anemia and megaloblastic anemia. Okay. Megaloblastic anemia is also found in folate deficiency, which is going to make more sense when we talk about. Point here is can cause neurological symptoms due to abnormal myelin, which is perithiasis. Perithiasis is basically a symptom of a patient presenting to you with tingling feelings in their hands and legs. Okay, so if they present to you like this, the first thing you should think of is B12 cobalamin deficiency. Okay, and this is because of the abnormal myelin. We're gonna talk about vitamin C now, which is ascorbic acid. Okay, so we know vitamin C is an antioxidant and it reduces LDL oxidation. It also keeps iron in the reduced state, including intestinal absorption. And it also synthesizes collagen, which is one of the most important things vitamin C does, which is why you can differentiate a vitamin C deficiency, okay? So here are some important points that Dr. Hannah just mentioned in her slides, so I'm just going to add them here. British sailors used to carry limes to prevent scurvy, which is one of the deficiencies caused by vitamin C. Also, deficiency in people are usually caused because their diet does not include fruits and vegetables, and instead their diet is more of tea and toast. So they're not taking fruits and vegetables that contain these vitamins, but they're taking tea and toast, okay? And here are some points that Dr. Hannah mentioned about vitamin C. It's essential for hydroxylation of proline and lysine. It's a cofactor for prolyl and lysyl hydroxylases. Addition of a hydroxyl group allows for hydrogen bonding between fibers, and without cross-linking, triple helix shape cannot form. So just read through these, okay? And the sources of vitamin C are going to be obviously green vegetables and fruits, like we talked. Okay. Now, ascorbic acid deficiency is usually, as we said, is caused by people that are not taking citrus fruits and vegetables, and the deficiency is given the term scurvy. And how does scurvy present? Is the patient is going to present with bleeding gums. Okay, there's going to be fragile blood vessels. There's going to be easy bruising, and there's going to be poor wound healing. So the patient is going to present to you, and the clinical scenario is going to go in the format of, okay, the patient presented, he got a wound, but it's not healing. And then there's poor wound healing, and then he also has swollen gums that are bleeding. Swollen, bloody, bleeding gums are a takeaway that it's scurvy, okay? Just if you read it anywhere, it's scurvy. It's vitamin C deficiency, okay? Okay, we're going to go to biotin now, which is B7. And this is required for ATP-dependent carboxylation reactions like pyruvate carboxylase. And pyruvate carboxylase converts pyruvate into oxaloacetate and takes it to the TCA cycle. Okay, and B7, which is biotin deficiency, is a really rare deficiency unless you start consuming raw eggs, because raw eggs contain the presence of evidin, which is a protein that binds to biotin. Okay, and when this protein binds to biotin, it's gonna not let this get absorbed in your body, and that is why you're gonna get deficient. Okay, so B7 is a rare deficiency. It's rare unless you start consuming raw eggs like 6 times a day. Okay. Now, the last water-soluble vitamin that we're going to cover is going to be folate. So we have folic acid, which gets converted into tetrahydrofolate, and tetrahydrofluorate is really important because it's a coenzyme for one carbon transfer methylation reactions, which is important for nitrogenous bases in DNA and RNA, which is kind of, if you remember, it's kind of similar to B12 cobalamin, which helps in the synthesis of thymidine, which is one of the bases in DNA. Okay, so the synthesis, a nitrogenous basis synthesis in DNA and RNA. So folic acid deficiency leads to neural tube defects. Just 1 second. Okay, so we're going to start with folic acid. Folic acid is converted into tetrahydrofolate, and tetrahydrofolate is an important coenzyme for one carbon transfer methylation reaction, okay? And it's important for the synthesis of nitrogenous bases in DNA and RNA. And we just talked about DNA and RNA in B12, which is cobalamin as well, okay? And a B9 folic acid deficiency usually causes pinna bifida. Here's a picture, and it's usually caused defects in the fetus, okay? And vitamin B12 deficiencies can also cause folate deficiencies. So because both of these vitamins help in the production or helps in the synthesis of DNA, so it makes sense why one would cause the other, okay? And here's a checkpoint. Are you guys paying attention? You guys want me to repeat anything? Am I going too fast? Is everything clear? Because I can repeat things if you guys want. Okay. Do you guys think my speed is too fast? Because I can reduce it. We're halfway done through the lecture, by the way. Okay, good. Okay. Why do vitamin, 1 second, there's a question. Why do vitamin B12 deficiencies cause B9? Okay, so vitamin B12 deficiency is vitamin B12 helps in the synthesis of thymidine, which is one of the bases in DNA, okay? And vitamin B9 helps in the synthesis of DNA and RNA. So let's say there is a vitamin B12 deficiency in a patient that's presenting to you, okay? And B12 deficiency already means that thymidine base is not being formed. There's no synthesis of thymidine base. And B9 also helps in the nitrogenous bases in DNA and RNA. One of the bases is already missing. So B12 deficiencies is initially going to cause B9 deficiencies because both of them correlate together. They're both working for the synthesis of DNA. Does that make sense? And B9 deficiencies cause B12? Yes, B9 deficiencies can also cause B12 because if a DNA synthesis is not working, then your entire DNA is gone, right? DNA is not being formed. So it can also cause B12 deficiencies. Is it clear? You're welcome. Okay. Okay, so we're done with water-soluble vitamins. Let's go with fat-soluble vitamins. Okay, so we only have four vitamins left to discuss, and the fat-soluble vitamins are A, D, E, K, and the easy mnemonic that I think Dr. Hannah must have given you is ADEC. So yeah, just really easy to remember. We're gonna be starting with what exactly fat-soluble vitamins are. So they're stored in the fatty tissues. They're not excreted in the urine as fast as water-soluble vitamins are. So when you take fat-soluble vitamins in your diet, they're actually stored in your body for quite a few time. For your metabolic processes, and then they're excreted out. So they're needed in small amounts and they're absorbed by enterocytes. So enterocytes are basically the cells in the small intestine. So they're absorbed by enterocytes, okay? Fat malabsorption, like Crohn's disease, leads to deficiencies of fat-soluble vitamins, okay? So if there's a fat malabsorption in your body, or if you're going through a disease where you cannot absorb fat well, you're also going to have deficiencies of fat-soluble vitamins because you're not going to be absorbing them well. Okay, and excess intake of fat-soluble vitamins has toxic consequences. Okay, so let's start with vitamin A. And vitamin A is often used as a collective term for several related biological active molecules like the retinoids. So we have the retinol, which is the primary alcohol, and then if you oxidize retinol, you're going to have retinol. So you're going to have retinol. If you oxidize retinol, you're going to have retinol, okay? And if you oxidize retinol, you're going to have retinoic acid, okay? So that's how it works. So retinol, you oxidize it, you get retinol. You oxidize retinol, you get retinoic acid. And you can also convert retinol back to retinol by a reduction reaction, okay? And beta carotene is just a plant form of vitamin A. And the sources of vitamin A are animal liver, you have cream, butter, egg yolk, and yellow and dark green vegetables. And fruits are good dietary sources of the carotenes, which are basically precursors of vitamin A. So functions of vitamin A are super important to understand for you to understand what deficiencies it causes. So we have vision, which is vitamin A is a component of visual pigments like rod and cone cells. Rod and cone cells are photoreceptors of your retina, okay? So if you have a vitamin A deficiency, there's going to be something wrong with your eyesight, okay? And that's called night blindness, by the way. And we also have growth. So vitamin A deficiency can also cause decreased growth rate in children. And vitamin A also supports spermatogenesis. For epithelial cells, vitamin A is essential for normal differentiation for epithelial tissues as well as mucus secretions. Okay. So we just talked about night blindness. This is one of the deficiencies that vitamin A causes, very important. And if it gets severe, then you have xerothalmia pathological, which is basically the dryness of your conjunctiva and cornea. So if night blindness gets severe, it's called xerothalmia pathological, which is basically when your cornea and your conjunctiva gets dry. So there's going to be like dryness in the eye, okay? And for toxicity of vitamin A, this is involved when you take excess vitamin A in your diet, okay? So if there's excess vitamin A, you have a syndrome that's called hypervitaminosis A, okay? And taking these chronically, which means for a long time, can be reflected in your skin, liver, and central nervous system, okay? And this is just diagram summing up everything about vitamin A. So we said that retinol, you oxidize retinol, you get retinol. You oxidize retinol, you're going to get retinoic acid. Retinoic acid is divided into two. We have tretinoin and isotretinoin, okay? And carotenes are basically taken in the diet, which are the precursors for vitamin A, which gives you retinol. Okay, and these are the four functions that we discussed of vitamin A. We said there's going to be maintenance of reproduction, vision, there's going to be growth and differentiation and maintenance of the epithelial tissue. Okay, for for teratonon, you need to know that it's more of a treatment drug. Okay, so it helps in the treatment of cirrhosis and the treatment of leukemia. Okay, whereas isoteratonon is more of a treatment of severe acne. Okay, so we're going to talk about isoteratonon, which is also called rioccutane, and this helps in treating nodular acne. And how it does that is it blocks the sebaceous gland. Now, what is the sebaceous gland? Sebaceous gland is basically a gland that produces oil on your skin, okay? So if you're blocking this out, the sebaceous gland is not working, which basically reduces the production of sebum, okay? Which is basically the oil, okay? And this kills the acne, which is caused by the bacteria. And it also reduces inflammation, which is the redness and the swelling around the area. So you can see here, this is the acne. And after the person took Rioccutane, the redness and the swelling is gone, and the acne is also gone and reduced, okay? The side effect of isoteratinon is there's going to be dryness of the skin, eyes, nose, and lips. Why is there? Okay. And it's also tetragenic, which is it causes birth defects. So you cannot give it to pregnant women. Okay, you cannot give it to pregnant women. So isotretinoin, it cannot be given to pregnant women, and that's one of the contraindications as well. We have women with childbearing potential, which basically means that if the woman is pregnant or she is about like she is pregnant or is pregnant, then you cannot give her isotretinoin because it's a side effect. It can cause defects in the fetus. Okay, so we're going to be covering vitamin D now. Vitamin D is very important. It can come in the exam. Okay, so vitamin D, there's two forms of vitamin D. So there's a precursor, which is 7-dehydrocholesterol, and there's an active form of vitamin D, which is 1,2,5-dehydroxycholesterol. Okay, and it acts more like a hormone in the body than a vitamin. Okay, so the body can make vitamin D with the help of sunlight. So how is active form of vitamin D from the precursor 7-dehydrocholesterol obtained or produced? So you take vitamin D3 from food or from sun, okay, and it's inert, so it needs to get activated, right? So you take it in the form of 7-dehydrocholesterol. And under the presence of UV light, this 7-dehydrocholesterol gets converted into cholecalciferol, okay? And then there's going to be two hydroxylation reactions that are going to happen. So the two hydroxylation reactions happen in the kidney as well as the liver, okay? The first hydroxylation reaction happens in the liver. The second one happens in the kidney. Very important to remember, okay? Don't get confused because in the liver, the hydroxylation reaction that happens is at carbon 25. So it's called 25 carboxylation. Okay, sorry, 25 hydroxylation. And if it happens when it happens in the kidney, it happens at carbon 1. So it's called 1 hydroxylation. It does not mean first hydroxylation. It means that hydroxylation is happening at carbon 1. First hydroxylation happens in the liver, which is 25 hydroxylation. Okay, I'm going to be explaining it here. So you have 7-dehydrocholesterol that gets converted into cholecalciferol with the help of the presence of UV light, okay? This cholecalciferol then goes to the liver where it's going to get converted into 25-hydroxy vitamin D, okay? Which is also called cholecalcidol. You can see here, I have written everything down. So you have 25-hydroxy vitamin D, which is cholecalcidol, sorry, and this is 25 hydroxylation reaction, after which calcidol, which is 25-hydroxy vitamin D, goes to your kidney and gets converted into the active form, which is 1,2,5-dihydroxy cholecalciferol, okay? And this is regulated by PTH. And here is an overview of what I just said, okay? The functions of vitamin D are very important. They increase calcium and phosphate absorption from intestine, and they also raise blood calcium levels. Okay, so they're very important for our bone. So if there is a vitamin D deficiency, there's going to be a defect in the bones. Okay, which we're going to discuss. Also, the deficiencies are usually caused by lack of sun exposure, uses of sunscreen, breastfeeding without supplementation, dark skin, obesity, and use of non-fortified milk. Okay, for the deficiencies that it causes, as we said, it's going to cause bone defects, and the bone defects are going to be rickets in children and osteomalacia in adults. Okay, so rickets in children is going to be continued formation of collagen matrix, but incomplete demineralization, which basically means that there's going to be formation of the bones, but there's going to be no demineralization. That means the bones are not going to be strong enough. Okay, so they're going to be soft, more prone to fractures. Okay, so rickets in children, whereas osteomalacia in adults. Okay, these are the two common deficiencies of vitamin D. Okay, now let's go to vitamin E. Okay, so vitamin E is also called tocopherol, and tocopherol is there's four different types of tocopherol compounds. However, only alpha tocopherol has vitamin E activity in humans. Okay, and it's the least toxic, and it's also an antioxidant. Okay, and it stops the reaction of free radicals as well as protects the oxidation of LDLs. The sources of vitamin E are going to be your vegetable oils, and vitamin E deficiencies are usually rare, right? But they can be caused by erythrocyte hemolysis. So erythrocyte hemolysis is when your RBCs start breaking down, okay? And hemolytic anemia can be treated with vitamin E. So we're talking about three anemias in this lecture. First, we covered sideroblastic anemia, right? And then we covered megaloblastic anemia, and then we talked about hemolytic anemia. Can someone tell me what deficiency causes sideroblastic anemia? Like what vitamin? Hembraiding? B6, yes. Yes, it's B6. Something related to iron, yes. So B6 vitamin causes sideroblastic anemia, and it is related to iron. You said right, Judy. This is when your synthesis of heme is not working, so iron starts accumulating in your RBCs. Okay. Megaloblastic anemia is usually caused by B12, which is cobalamin. And then hemolytic anemia, we talked about it here, and we said that it could be treated with vitamin E. However, it's not the primary treatment, but it can be treated with vitamin E, okay? And vitamin E deficiency usually occurs in premature infants. Okay, we're on our final vitamin, guys. Vitamin K, okay? And vitamin K is also known as phyloquinone, menaquinone, and menadione. Okay, and it's produced by our intestinal bacteria, which makes it unique. And it is essential for blood clotting as well as bone health. Blood clotting is a very important factor of vitamin K because it helps as a cofactor for clotting factors like 2, 7, 9, and 10. Okay, and it activates blood clotting proteins, so they help in not letting you bleed out when you get an injury. And there's also bone health, which basically activates osteoclastin, which helps bind calcium to bone matrix. There's two main forms of vitamin K. We have phyloquinone and menaquinone. Phyloquinone is K1, called K1, and menaquinone is called K2. Phyloquinone is taken up or found in leafy green vegetables. Okay, and K2, which is menaquinone, is produced by our gut bacteria. However, vitamin K2 has broader functions, which is menaquinone, produced by our gut bacteria, has broader functions than K1, which is obtained in the diet, okay? Regulating, and what it does, it basically regulates calcium metabolism in tissues, and it prevents calcium buildup in arteries, which is really important because you don't want buildup in your arteries, right? And it also supports bone health by activating osteoclastin. So, vitamin K2 production, obviously by the gut bacteria, as we discussed, depends on factors like diet, antibiotics, and gut health. A healthy gut microbe is the key to optimal K2 synthesis. Okay, fermented foods and probiotics can support gut health. However, antibiotics do not support gut health and can disrupt the gut bacteria and reduce vitamin K2 production. So, you need to have a balanced diet with probiotics for you to have good gut health, for you to be able to produce K2, which is menaquinone, for you to not build up calcium in your arteries. if that makes sense. Does that make sense? Do you guys want me to repeat that? Because these 2 points are important. Good, okay. For vitamin K deficiency and toxicity, for the sake of completion, I have added this, but in your slides, it's not mentioned. Dr. Hannah did not cover this for you guys, so it's not important to know, but as a basis, just read through it, okay? Vitamin K deficiency is usually, it happens in newborn infants. However, vitamin E deficiencies is in premature infants, okay? You know the difference, but. And newborns, they have a sterile intestinal tract, so you need to give them a single shot of vitamin K at birth, okay? For vitamin K toxicity, it's if you give them prolonged administration of large doses of synthetic vitamin K, like menadione, it can produce hemolytic anemia and jaundice in the infant due to the toxic effect on the membrane of RBCs. Just read through it. You guys don't need to know just like, you know, like over the top because it was not covered in your lecture, but it's here for the sake of completion. Okay. Here's a checkpoint and we're done with the lecture. We just have questions. Do you guys have any questions? Do you guys want me to repeat anything? Okay, so we're going to be going to our questions and yeah, let's start. Okay, so I'm going to be highlighting the important points in the questions and you guys are going to tell me the diagnosis or what the answer is, okay? So a patient presents to the ER with symptoms of tender gums, weakness, and muscular pain. On physical examination, they exhibit paleness, sunken eyes, and tooth loss. Which type of vitamin deficiency is most likely responsible for these symptoms? Good job, it is A. Can you tell me what vitamin this is and what's the deficiency? Vitamin C, right? Do you know the name of the deficiency that it causes? Scurvy. Good job. Okay. Next question. I'm going to answer your question in a bit. I think Samir asked that question. I'm going to answer it in a bit. Okay. So a smear of your patient's blood is shown in the following picture, demonstrating that a person suffers from a form of anemia. Okay, a deficiency in which of the following vitamins would lead to anemia that is shown in the picture. So talked about 3 anemias, guys, if you remember. Oh, my bad. Hold on 1 second. Not zero. Okay. Megaloblastic anemia. Yes, this is a picture of megaloblastic anemia. Can someone tell me what causes megaloblastic anemia? Which vitamin it is? Cobalamin. Good job. So cobalamin B12 is what causes megaloblastic anemia that you can see here. No, B6 causes sideroblastic anemia. B12 causes megaloblastic anemia. Okay? I used to be confused too, guys. Don't worry. You're all gonna get used to it. Okay. So we have another question, which is a patient presents with inflammation of the lips, scaling and fissures around the corners of the mouth, and a magenta colored tongue. These findings are most consistent with the deficiency of which of the following? We discussed this in like the first few slides. It's not NAD. Yeah, it's B. It's FAD and FMN. And if you guys remember, if FAD and FMN were also called B2, which is what causes your 3 symptoms. You remember gliosis, glossitis, and corneal vascularization. The lip scaling and fissures at the corners of the mouth are basically gliosis. That's how you spell it. And magenta colored tongue is glossitis. Okay. For NAD, it is B3. NAD causes pellagra. the 3Ds, the dementia, diarrhea, and dermatitis. That's what NAD causes, the deficiency of NAD causes. Okay. For vitamin D, we have a question too. When vitamin D is deficient, what two disorders occur most readily? E. Yep, good job. E, because we said that it helps in the bone health. So if there is deficiency, it's gonna have bone defects like rickets and osteomalacia. Can you tell me which one is in the kid? Like which one is in the kids or in the children, and which one is in the yes, rickets is only in the young, yes, and osteomalacia is in the adults. Good job, guys. You're doing really good, mashallah. Okay, so which one of the fat-soluble vitamins is responsible for blood clotting? Yes, vitamin K. Good job. Okay, let's go to our last question. And where does vitamin D get converted into its active form? Skin? Do you want to go again? Skin is not even in the option. Yeah, UV does convert it, but it's not the active form. It is C, yes. It's kidney and liver. This is where your vitamin D gets converted into its active form. In the skin, it just gets converted into like it's inert, and then it gets converted into cholecalciferol, which then goes to the liver and the kidney to get into active form. Does that make sense? Also, can someone tell me where the first hydroxylation happens? Is it the kidney or the liver? Liver. Yes, good job, guys. Okay, that is about it. And you guys can scan the QR code for the feedback form. And thank you so much for attending and listening. And if you guys have any doubts, I'm here to clear them up. Oh, is the QR code blurry? Can you guys scan it? You're welcome. Oh, okay, Samir asked, do you have any tips for how to memorize all these vitamins? Is Anki best, or should we look for mnemonics, etc.? Honestly, go over the lectures as much as you can. Try solving past year question papers, and you'll know how to differentiate between each vitamin because none of them are similar except like B6 and B12. That is the only one that's gonna confuse you. So you can look through Anki. Anki is a really good source to study for several vitamins, and even mnemonics work. Yeah. Okay, guys, thank you so much for attending. And inshallah, you guys are gonna ace the exam. Don't worry, we're gonna all pray for you.